Hello and welcome. My name is Carmel Roth. I'm the managing editor of Side Effects Public Media. And on behalf of Side Effects and WFYI, it's my great pleasure to welcome you here today to join this vital conversation on the opioid epidemic and its impact on minority communities. We're grateful to our partners in planning this event, the Indiana Minority Health Coalition, and to all of the panelists for being here today. We are also very happy to welcome an audience around the state via viewing parties that the Indiana Minority Health Coalition has put on, and also via YouTube. It's great to have an audience in person and online, and we'd like to invite you to join the conversation with questions, which will be taking place in the last half hour of the presentation, but you can submit your questions at any point via YouTube live chat or via Twitter, using the hashtag #INMinorityOpioids. That's #INMinorityOpioids. Or you can tweet directly at us at @SideEffectsNews. And that's the best way to reach us, and we do hope that you join in and submit your questions at any point during the conversation. Our moderator, Michael Twyman, we're very happy to have him here today leading the conversation. He is the owner of a consulting firm called In Excelsis here in Indianapolis. He's also faculty at the IU Lilly Family School of Philanthropy, where he teaches courses on race and social justice. Welcome, Michael.
Thank you, Carmel. It's a pleasure being here, and welcome to all who are in the audience and are at a distance. It really is about having a conversation today, a very important conversation. Major opioid crisis, actually arguably two crises, one affecting whites and one affecting communities of color. And so today we're going to really explore the implications of those differences and the disparities between the two. And it gives me great pleasure to introduce our panelists, very esteemed panelists that we've been able to bring here today and to engage in this conversation. First, joining us via Skype is Dr. Ronald Sullivan. He is a leading theorist in the areas of criminal law, criminal procedure, trial practice and techniques, legal ethics, and race theory. He is the faculty director of the Harvard Criminal Justice Institute and the Harvard Trial Advocacy Workshop. Welcome, Dr. Sullivan.
Thank you very much.
We also have Jocelyn Whitaker. She's from Marion, Indiana, community leader and the president of the Grant County Minority Health Coalition. She is an education consultant, an instructional coach in curriculum design, and a member of the Board of Works and the Area Planning Commission. Glad to have you, Jocelyn. Brad Ray. Dr. Ray research focuses on mental health and substance abuse, particularly where the populations connect with the criminal justice system. He is an assistant professor in the School of Public and Environmental Affairs, SPIA, at Indiana University, Purdue University, Indianapolis, and director of the Center for Criminal Justice Research. Welcome, Dr. Ray. And Dr. Bush, who is a physician, an expert in interventional pain management for both acute and chronic pain. She is board certified in anesthesiology and pain management, focusing not only on alleviating patients' long-term pain symptoms, but also on providing medical treatment options to patients seeking immediate relief from the sudden onset of back, neck, muscle, or joint pain. Welcome, Dr. Bush.
Thank you.
So let's open it up, and I'm going to actually direct this question to you, Ronald. We had a state senator in New York that said it's not a ghetto drug. It's happening to doctors' kids. In the context of our discussion today, what's your reaction to this notion that it's not a ghetto issue or something that's manifesting itself in the ghettos of our community, but this is happening to doctors' children?
Well, it's a very clear sign to my thinking of the way criminal law is practiced and has been practiced in the country for a very long time. That is to say, the African American community has had an epidemic with respect to drug addiction of a certain type of drug for a very long time. The vocabulary was consistently criminal. When other communities began to experience addiction, then the vocabulary changes quite dramatically to a medicinal vocabulary. That is, treatment is the first stop. Now, I think that's the correct vocabulary and that all communities should be treated like this. But it is quite consistent with the way in which criminal law is practiced. And it's for the following reason. So one scholar puts it this way. He says that we ought to localize criminal law. What does he mean by that? He says that the people who tend to make the statutes, that is the laws that govern the criminal courts, the impact of those laws tend not to impact them, their children, their nieces, and their nephews. Because if it did, they wouldn't write them in such a draconian fashion. This is a prime example. When the scourge of drug abuse began to creep its way into certain communities and people began to be impacted by them, then their consideration of those things changed. It's no longer this vicious criminal thing that needs to be dealt with. Instead, it is a medical issue that needs to be dealt with in treatment. So hopefully the country is learning from this, has learned from this, and will begin to treat drug addiction for what it is, a medical issue.
Other reactions from our panelists around both the quote and comment or this notion of maybe things only being public policy or becoming issue or crisis when they affect a certain segment of our population?
In reality, since I have been a lawmaker and a city council person, I've seen that work. And if you look at the state legislature and so on, if you look at how we deal with the issue of overdoses right now with the opioid problem and how we deal with 3 strikes and you're out for marijuana, there is a huge gap because the person who is overdosing is taking an illegal drug. Yet we revive them and let them go on their way. The person with the marijuana, we lock them up. Go to 3 strikes, they go for life. And usually that affects the black community or the minority population than anybody else. I raised this question recently, probably 2 weeks ago, at a town hall meeting. The question was not addressed. And there were 5 of our 7 legislators there. And and the reason we have so many is because of the redistricting. In the state of Indiana, the legislator chooses who his voters will be. The voters do not do that. So as a consequence, we are represented by all Republicans. And the issue of how we will deal with marijuana was never addressed.
Let me read a comment that was submitted on the Side Effects website in response to a story about Indiana's newly approved work requirement for Medicaid, which is called HIP 2.0. Screw the poor who can't work, but give junkies $80 million so that they can get healthy, right? I say give them a good dose of Chinese fentanyl. So, does the stigma extend equally to all users when it comes to black, white, poor people, and those who typically have choices, resources, and access to care?
I think that the attitude's a little bit different when we talk about older adults that are overdosing on accident, right? We don't think of them as quote-unquote junkies, but older adults who may take prescription medications, accidentally take too many, accidentally take them with other substances and overdose, we don't tend to refer to them as junkies, right? So I think junkies has a different sort of stereotype to it when we talk about that population. But that is a lot of the individuals who are being prescribed opioids and a lot of the individuals who are having overdose events. Non-fatal and fatal overdose events are older adults too, so.
And are there racial overtones to this as well?
Yes, there are. The reality is when blacks were taking heroin in the late 70s and the 80s and so on, it wasn't a crisis because it was in that community. Since it has become a majority community issue, there is a crisis in this country and how we will deal with that. Yet, we still have not gotten our our legislative body to understand how that impacts, because we still have people who believe there's no racism in this country. So with that in mind, how do you deal with a situation when you look at how people are sentenced in the state of Indiana and this country? You start to see the disparity in itself.
So there's, throughout the criminal justice system, as you're alluding to, there's just structural racism, right? So African Americans, whites have no difference in their likelihood to use or abuse drugs, but if arrested, more likely to be arrested. If arrested, more likely to be sentenced, and if sentenced for harsher punishments and further time, right? So this is throughout the entire criminal justice system, and I think one thing I think we'll probably talk about it a bit, but as this epidemic did start out, largely a white epidemic, it has moved into African American communities. And so I think one of the most frightening aspects about using the criminal justice system to address this problem to me is that it would disproportionately affect African Americans to use a system that already has such structural, racism embedded in it. So I think that's one of the bigger concerns, that as we see this moving into African American communities, using the criminal justice system could be potentially problematic.
Ronald, do you have some insight on that too, the whole criminalization of the issue?
No, indeed, it's deeply problematic. So what we see and what sociologists and criminologists have shown is that in the country, color tends to be a proxy for criminality. So the same sort of conduct that we see in one community is read in one way, but that precise sort of conduct that we see in another community is read with a criminal law lens. I'll give you an example from my vantage point here in Cambridge. Right here on Harvard University, I can pretty much guarantee that it is as much illegal drug use as there is 2 miles away from here in a black neighborhood. It's called Roxbury. So I can guarantee you there's the same amount of drug use, but in one community here on campus, for example, it's treated in a different way. It actually is treated as an addiction problem. In Roxbury, people are being dragged away in chains, and that's a problem with the criminal justice system that we as citizens have to fix. It is true, the data show that blacks and whites don't use drugs in any appreciable difference. They use it at about the same amount on a per capita basis. However, African Americans represent over 60% of people nationally who are incarcerated for drugs. That alone should at least make policymakers and legislators begin to think about the way in which the reach of the law is impacting communities differentially.
Right. Dr. Bush, kind of on that same note, you don't work in the criminal justice system, you're in, of course, the healthcare system, the medical system. This issue of access and use relative to both illegal and legal drugs, speak both historically and what you see in terms of maybe racial overtones to how that's looked at.
I mean, historically, if you look at some studies, they show that for whatever reason, medical professionals might have some prejudice towards minorities, and that minorities were traditionally either thought that they didn't experience pain as much as whites, or that they would misuse or abuse the medication such as opiates, right? So they weren't given opiates, and white patients were traditionally given this. And so I guess if you look at the studies and some of the literature, blacks were sort of insulated from the initial phase of the opioid crisis because we weren't given prescription painkillers. But what's happened now is that as we've decreased how much we're prescribing by the CDC guidelines, and we're decreasing the sort of the pill burden that's out there, drug dealers or whatever are now seeing this opportunity to then flood the market with heroin and fentanyl. And so now, because drug dealers don't care about the color of your skin, right, they are now letting or selling to both blacks and whites. So I mean, I think if you look at, that's why there's the rise in sort of the black overdoses that are coming now, and it's more fentanyl and heroin and not prescription opioids.
In terms of this issue of shaming and shame, if there is such a thing, I know, Brad, you talked about earlier on one of our discussions that some may see oftentimes use and overuse as a moral failing. Do you think that that's still true, and is that more so prevalent in communities of color versus the majority, and around the issue of it being a moral failure?
Yeah, I think so. One thing, it's difficult to talk about persons of color in the United States without kind of just laying out, that there's been structural inequalities for the existence of our country. So those persist today and really manifest themselves in differences in socioeconomic status. And so I think one of the reasons is we see African Americans having less likely to have insurance. So they're less likely to be getting some of these prescription drugs, as you noted, right? And this is largely due to, as I said, structural inequalities that have manifested in differences in socioeconomic status. So I think when we talk about there being a lens of moral versus immoral, I think it is based around race and ethnicity, but I think it's also based around social class. Poorer people are seen as sort of the more moral failing, right? Because they are unemployed, because they potentially have, persistent mental illnesses, because they have other sort of social barriers around getting treatment. So I think we tend to see those individuals as having moral failings, whereas the person who took too many opioids after they had their dental surgery, their dental event, or who took, interacted with alcohol, those individuals are seen as more having accidents. And then there's those individuals that have insurance that can get diagnosed with opioid use disorder. So then, as you had pointed out, then this is a more medicalized approach to it. So I do think that there are different approaches to this, and they're based on, race, ethnicity, and I think class and access to treatment and services. Right. So.
Jocelyn, would you say that some of the rhetoric maybe around moral failure comes from corners of our faith community?
Most definitely. And I'll give you an example of something that has happened in our community. Grant County has 70,000 plus people. It was so bad in 2017 that I had a white minister tell me, who was a friend, because I worked with and led one praying for Marion and Grant County, because we were having such a huge problem with it. But it was so bad, the parents did not want the obituary to appear in the paper. And as a mother, sister, and so on, I thought to myself, I said, I hope that I never get to that point where I'm afraid or I feel that I'm shamed that my child did something and that would be looked upon as a moral failure for me.
Right.
Because at no point would I hope, get to a point where I would not want to celebrate my child's life. Because my Achilles arch is my son, and I'll be very frank. And I think any parent would say that, and to deny that celebration of life and maybe have something on Facebook or whispered about. And I understand where the parent is coming from too, but to say that that person did not exist. Right. And that's what bothers me, because to me, that's a mental flaw. That's a mental illness, and that's something we haven't talked about in this discussion. Why do people go to that extreme? Not to let or accept that something could have happened. And you are not to blame.
Right. Others of you want to add to that?
Yeah, I can jump in. The point about mental illness is excellent. Our prisons are filled with the mentally ill. So I think that we as a culture do a very bad job at recognizing aspects of personality that don't fit well within the criminal justice system. So the criminal justice system is too blunt an instrument to be able to deal with many of the social ills that lead to at least a formal violation of the criminal law. So, and oftentimes with forms of mental illness, people self-medicate. And if you treat that criminally, you're not moving down a path of rehabilitation at all. So I think that we have to think a lot more strategically and a lot more creatively about how to push people away from the criminal justice system rather than warehousing people within the criminal justice system.
Yes.
And just to follow up on that, I think a lot of the reasons that the police and law enforcement use jails and incarceration so frequently is it's the one place that cannot turn anybody away, right? So you can take somebody to a treatment provider, they can say, we've had problems with this person before, we don't take people like this, but that's the one place, and there's research showing that when police have a 24-hour, no refusal drop-off location, that they do want to drop people off there. And they will drop people off there. So I think we need to think about when we don't have other treatment options available, that's when the criminal justice system becomes sort of the court of last resort, if you will.
Right.
So.
And not only that, we need to look at training, because my background is education. We need to look at educating and training our police officers how to deal with mental illness, how to deal with drug overdose, and so on. And that is a very scary thought, because nobody would like to admit there's a family member who may be a little odd or different.
Mm-hmm. And I saw a study recently, and I don't remember the numbers exactly, but it was like, I think over half of these police encounters are with persons. That's like the group that they're most likely to see are persons with mental illnesses. And they did a survey of all these criminal justice programs across the country, and less than 20% actually teach officers. So we're educating officers on all these other components, but the population they're most likely to intersect with, we're not actually teaching them how to deal with that population. And I think that should just be a systemic change across the board in how we're training our criminal justice professionals moving out into the field. So
this segues nicely into my next question about perhaps there being an arc in the opiate epidemic, starting for perhaps prescription of opiates, and in some with use disorder, and then seeking heroin on the street. Are there differences for how African Americans and other racial and ethnic groups compare to whites and what happens at various points along the way? So starting from being prescribed to perhaps going to the street in order to get your fix. Can you speak to that, Dr. Bush?
I can address it a little bit, I guess. In terms of like prescribing, like we said, there's, for whatever reason, that bias that might have initially begun where minorities were not given prescription opiates. And so they then, if they were in pain, were then going to possibly seek other avenues to get medication, yes. And then in terms of like, primarily, if you're looking at whites and they were given those prescription opiates for their pain, then they would take them home, right? And so then you have the diversion issues where people were then letting my best friend or my husband had a pain. And then we found that like children, and that's sort of how it sort of progressed to the children of the doctors are getting prescribed or getting, addicted to these medications. And the arc might be that in that regard, that they had the medicines at home, that they could use them and then get addicted and get abused in the wrong way. Because clearly they're not taking them for pain. They're taking them, as we talked about, for mental illness, whatever, or because they want to fit in, or because they think this will make them not care about school or not care about whatever relationship issues they're having. And then I think, as we said, just going back to the bias, it's easier for them to get them again. I think experienced prescribers, right? So I'm a pain physician. I'm experienced in prescribing my medications. I see my patients monthly. I'm going to evaluate them. I'm going to make sure they're appropriate. They're taking their medicines appropriately. I'm going to look at their inspect report, which shows when they filled their medication, and we're going to count medication as well. We're going to do urine drug screening. Some providers don't even have the ability to do that because of busyness, because they have such a large patient load, or because they're not even skilled in terms of knowing how to prescribe opiates in the correct way. And so then they're saying, Joe Schmo called in for a refill, well, I'm going to give him another one because they've been a good patient. And it sort of just continues like that. So.
And I do think that there has been, we described this earlier, as kind of an arc over time. Like we're saying, like initially we saw this as individuals. And I think that that arc largely goes across socioeconomic status lines, right?
Mm-hmm.
So initially, individuals who had insurance were getting these medications.
Right.
They were abusing them, and we've seen this sort of change over time. One of the things we've done here to get to the INSPECT, so INSPECT is our, for those of you that don't know, it's our prescription drug monitoring program. So doctors input information on patients and can check the information on patients that have had scheduled substances. And so we've done a study here where we looked at individuals. So we look at all of the cases of folks that died over the past 2 years. And we've seen how many of them have actually had an INSPECT record. Surprisingly, only about half are even in INSPECT, which is illustrative of the point that many are just using illicit substances. And very few people are actually just dying from the prescriptions that are prescribed to them. Mm-hmm. And that's primarily white females when we look at that group, so dying of just the substances that were prescribed to you. But there is a significant difference in by race and the likelihood to have even had INSPECT. Less than a third of black decedents ever had an INSPECT record in the year prior, compared to about half of white decedents. So there is this sort of disparity, and I think it's partially being driven by access to treatment through insurance. So,
while you're on that same note, are we seeing things differently in how it's playing out here in Indiana or even in central Indiana?
It's hard to say. I mean,
are we following national trends?
Yeah, I think we are. The big thing now is fentanyl. So half of all people that die in this county have fentanyl in their system, and we're seeing this across the country. So yeah, I think that we're seeing a similar trend here of the movement towards fentanyl and away from heroin, fentanyl being a much more powerful drug. So,
well, why is it that until lately the vast majority of those caught up in the opiate crisis have been white? It's been only recently, within the past couple of years, that the numbers of African Americans have been rising and rising fairly rapidly. What do you think's behind that?
I don't have data to back this up. Dr. Sullivan may have some additional studies that he knows of, but I think we're seeing a movement changing in dealers. I think dealers are kind of moving into fentanyl, and I think sometimes, from what I've heard anecdotally from coroners, dealers don't know how to break this stuff down. So if you don't know how to break down fentanyl and you're putting too much in a bag, right? Then that's every bag that has too much, that's a dead body, right? So, yeah.
Dr. Sullivan?
Yeah, if I were as sophisticated as my teenage son, I would be able to put a graph up here and show you guys. But from 2008 until now, if you could see the scope of the graph that shows deaths of African Americans from various opioids, it is stark. We are at a level in 2008, it was somewhere around 8 per 100,000. And now it has skyrocketed to over 16 per 100,000. And that is the level that whites were at in 2014. So from 8 to over 16, it is just skyrocketed in recent years. So this is a cross-cultural, cross-racial American problem that we have to deal with. And to the speaker who mentioned fentanyl, that's absolutely correct. That, pardon me, fentanyl is the new game in town. It is extraordinarily dangerous, and the data that we're going to see, unfortunately, I think a year from now, as we look backwards, is going to be startling. So for people who think in epidemiological terms, for people who think in public health terms, this absolutely is a public health crisis that has to be and should be dealt with responsibly.
And part of the reason we haven't seen the fentanyl before now is we actually don't do a very good job of tracking these different types of substances. So when we track the national death data, we have what's called ICD codes for heroin, we have ICD codes for synthetic opiates, but we don't have an ICD code that's specific to fentanyl. And so it's really, that's what people are dying from right now, is fentanyl. And I think we talked about this, and I don't know if you have any additional information on this, Dr. Sullivan, but I think my understanding is most of the fentanyl is coming in from China through our ports.
Dr. Bush, following up on that, it's kind of a three-part question, but any views you have on fentanyl and the use of it and maybe the rise of it, but then two, speak from your practice experience and particularly what you do at the Pain Management Center. What are appropriate circumstances, and I know it's case by case, where opioid being prescribed is the right thing, number one, and then three, a number of other options that are available to patients in terms of managing pain?
Right, so in terms of the fentanyl being on the streets, like it's sort of it's an odd thought, because in anesthesia and in pain management, we don't see powder fentanyl, we see liquid fentanyl, or we see it in a patch. And so the fact that it's been purified down into a powder is actually, it's mind-blowingly scary. It is a very strong drug. When we administer it, we give it micrograms, and that's by a nurse or a doctor giving it through the IV, monitoring the patient. That's how quickly it could stop you from breathing and all those things. And so it boggles my mind that people would want to do that.
So highly lethal under uncontrolled circumstances.
Yes, absolutely, yeah. Absolutely. A medical professional needs to administer fentanyl.
Yes.
In terms of like other options and sort of why you treat an opiate, there are many reasons to have pain. There absolutely are. You don't want to treat acute pain that might be a muscle injury or a little sprain with like a large dose of opiates like fentanyl, definitely, but like, Vicodin or Percocet. You might want to start initially with like, an NSAID, which might be an ibuprofen or a Motrin, or you might want to start with a muscle relaxant, resting, icing. In terms of patients that do get opiates, those are patients who've had major surgery, who are dealing with significant limitations in function due to like scarring and hardware, and these people can't stand up, much alone go to work or to do their ADLs, which we call or basically your activities of daily living. These are the things you have to do just to take care of yourself. And so we assess our patients. We don't just say, a patient can't just come in and say, oh, I hurt. No, we're gonna do a physical exam. We're gonna have some history. We're going to do some diagnostic studies. We're going to document why you're in pain. And then we're going to treat you accordingly. We're going to give you small amounts, and we're going to see how things go. We're going to have you determine and tell us your pain level, your functionality. How are you doing at home? Are you doing your physical therapy? And that sort of leads me into the other options that we offer patients. So let's say you have a herniated disc and you have pain down your leg or in your arm. We'll start maybe with some medication, but then we're going to say what we need to do after the diagnostic studies is possibly do an epidural injection. And epidurals are things that we do with our interventional procedure that we can place steroid next to an inflamed nerve. And that's not an opiate. That's not something that you're addicted to. And it's going to ultimately improve your functionality. We also have, a number of other injections for arthritis, for chronic pain as it is. We have infusions. But we also have the option that if opioids really are what you need and that you can't sort of manage on the smaller doses that the CDC are telling us that we have to give you, we actually have implantable devices called like an intrathecal pump, where you put a catheter in your spine and we control how much opioid you get. And it's 1/100th of what you're getting orally. And there's no way to manipulate it, there's no way to divert it. And that's a way to treat patients with chronic pain.
Excellent. Around this issue of access and going for treatment, a lot of course, we know the patient-doctor relationship. If there is no modicum of trust, meaning the patient presented themselves in a way that, one, they're truthful, but two, also feeling that the person on the other side of the examining table is going to believe them, going to value them, or even treat them fairly. Does that factor into this equation around this issue at all, the issue of trust and mistrust?
I mean, I think like studies have shown that African Americans have a distrust of healthcare. I mean, they feel like either they're going to be experimented on or not treated fairly, which, like we said, studies have shown that they're not prescribed opiates to the same degree that non-minority patients are. I think as a physician, when I look at a patient, I don't look at their color. I literally do the same exam on somebody if they're white versus they're black or Latino or Asian. I'm going to do the same diagnostic studies. I'm at the same requirement for medical records, for urine drug screening. And I'm going to ask them to do the same things that I'd want anybody with the same condition to do, meaning physical therapy, intervention, psychotherapy. And so it's hard for me to address that,
Sure.
being a minority myself.
Or do you think there are perceptions that people in minority communities, particularly African Americans, have about the system, if you will?
Of course. They have it about all systems. And if you were to talk to the average person who's on the street about Dr. Bush or myself, they're one of those people. But yet, the people who are overdosing in the streets are not seeing Dr. Bush as their physician. They are not talking with Jocelyn Whitaker or the NAACP or Minority Health about the issues that are coming, that they have. And 9 times out of 10, the person who is dispensing the drug is not a medical doctor. So they're getting it from the pusher on the street. The pusher on the street doesn't know what is in that substance,
right,
because he got that substance and he is pimping himself out to make money for his family. See, the problem is so complex, and it's very easy for us to sit on this panel and say, hey, you ought to be doing this and you ought to be doing that. But for the person who is on the streets, they perceive us as the establishment, here you go again, telling me what to do. Not as I'm talking to you about something that could save your life, or you being allowed to be a father to your children, or mother at home, and so on. The issue comes down to this. I have a problem, and that problem could have come from cultural, social mores, and so on, that caused me to move to this. How many times can I be told no? How many times must I go and hit my head against a brick wall? I went to the minister and he didn't understand. I saw something Saturday night with Rosa Parks and her story. And it was wonderful because it talked about how Dr. King had gone to other ministers in the first part of the civil rights movement. Some were accepting, others were not. And are we accepting of our fellow man? And it's not just in the black community, it's in all communities. Why are people turning? Again, that mental health, that well-being, that acceptance. The gang in the streets is much more family friendly than the family we have a lot of times. And that's a scary thought, because people turn to different things for different reasons. And we've gotten into a point which is very scary. We want to be our kids' friends, not the person who provides guidance, not the mother, the father. We don't want to deal with that. My job, if we have a job, I have to deal with that. But I don't want to come home and deal with that.
Dr. Sullivan, you're nodding your head. Could you also maybe just speak to what's the appeal on the street? What draws people and what keeps not only the market going, but this whole issue of gotta feel good? Do you think that is a big part of what drives folks to continue to go for it?
Well, I think so. My colleague here at Harvard, Dr. Cornel West, describes it in the following way. He says that there's a pervasive sense of nihilism in young black communities. That is to say, the notion that there is no future, that there's nothing to look forward to, there's nothing to live for. And this pervasive notion of nihilism fuels self-destructive behavior. And I think Professor West is really onto something there philosophically, as that helps explain why we may engage in starkly or decidedly self-destructive behavior. I did want to pick up, if I may, on this notion of distrust too. I actually just pulled up some data and took a quick peek at a couple of the very recent studies, and the notion of distrust among physicians in Black and brown communities is much higher than it is in any other ethnic community, in any other community, period. And now, with respect to the African American community, I did want to add that this doesn't just grow out of whole cloth. You see, the Tuskegee experiments, for example, is still in the lived experience of at least my parents' generation. So people grew up, like me, hearing about the Tuskegee experiments and so forth. And there is a very pervasive distrust in the African American community that is born out of the lived experiences of our parents and grandparents. Now, I happen to have grown up in nearby Gary, Indiana, so all of my healthcare professionals were African American, and so I never felt personally this notion of distrust, but I certainly understand it conceptually. So when the foundation of trust is broken down between physician and patient, then that necessarily is going to lead to bad decisions. Either the patient not being as fulsome with the medical professional, or even worse, the patient never going to seek out medical care and self-medicating by going to the streets to get the sorts of things that are again self-medicating. You know, the notion that there's something wrong, but medical professionals could really be of assistance, but there's a disinclination to go there, so you find it elsewhere, and that's a real danger.
Right.
Before we leave that, let's talk about something that's even closer, Vietnam, and the mistrust with Agent Orange, and how our soldiers, I had two brothers who served in Vietnam, and thank God they came home alive, but mentally it's something else. And one went on to be a doctor, and he lives out in Seattle. And the other one would probably make a good Baptist minister because he could talk you into anything. But he's had problems with drugs and so on. That mistrust not only goes with the medical profession, but it also goes with our government. And look at how we have treated our veterans. So should that mistrust be there? Oh, definitely, yes.
Right. Well, the whole issue of PTSD, historical trauma, that's all in the mix here. Doesn't go away. It just continues to get passed on to generation to generation.
I don't think it's by any means a solution, but one thing I've seen that has been a powerful way amongst people who abuse opioids or use opioids is harm reduction. I don't know if we're going to get to that eventually, but harm reduction, this idea that we're trying to reduce the amount of harm, even though you're doing these potentially dangerous activities. Now, within that idea of harm reduction, you know, I first saw harm reduction really play out in a syringe exchange in Chicago. And it was there when I saw that, I recently heard somebody describe, well, they just give them needles and they give them cotton and they just give them all the materials, but they give them something else that's not tangible, which is this sense of hope that there's these people out there that care about you. And you might not have, I mean, we take for advantage all the hugs and the nice stuff that we get on a regular basis, but these individuals can get that love and acceptance for the first time. And I think that philosophy may be one tool that we have to address some of these trust issues, if harnessed correctly. So,
a term we often use in different professions. I don't know how vogue it is in terms of the medical profession, but we often talk about cultural competency. You talked about with your patients, when you treat them based on their medical need, but I'm sure you're also sensitive in terms of their health history, other cultural determinants that might be playing into that. How do we, and then you also have shared that you work with a multidisciplinary team. how do we marry criminal justice with the healthcare profession and other professions that have different pieces of this issue so that we're working together and we have a better understanding of the nuances of race, socioeconomic class, education level, and access issues as well across the systems?
Well, I mean, I don't know if this would be in the medical system per se, but within the criminal justice system, I know Dr. Sullivan's done some work in drug courts as well, and I think drug court, the evidence suggests that these work, but one of the biggest failings is that there are some inequities by race and who completes these courts. So one thing that my folks that my research team have been looking at are some culturally tailored interventions. Mm-hmm. And shockingly, there are no culturally tailored interventions for African American males in the criminal justice mm-hmm. system. I mean, that's just a shocking, given how the pervasiveness. So I think
yes.
that thinking about culturally tailored, and even within that idea of culturally tailored, they can be surface where you just have somebody of the same gender, race, ethnicity, mm-hmm. or they can be, deep structured where they're addressing historical trauma, where they're addressing, structural mm-hmm. disparities. So I think that's one thing in a lot of our areas that we have yet to really tap into, mm-hmm. are designing, culturally responsive mm-hmm. in both the medical and the criminal justice world. Right. I think we need to do a lot better job at that.
And I know you've seen it in education.
In education, we are warehousing our black males, and we can't figure out why is he so angry. It's a mental health issue. When you have not grown up in a household where there is a father role model, whether it's a father, uncle, grandparent. For years, historically, we were not a nuclear family, but the neighborhood had that character. It had a cousin, it had an uncle, or someone who stepped in the gap. We're not having that right now. And we wonder why our children are so angry. I am a female. I could not teach my male son how to be a man, but his stepfather could. When I went through my divorce, I was so angry. There's that mental health that I could have transferred to that male child. And probably at some point I did. I would love to say I was perfect, but I'm not. And when you have males seeing only females, you're going to have some tendency to see some things you don't particularly care for. Some feminine tendency. A friend of mine just was talking about that, the feminization of the black male in the black community and so on, and some identity issues that come with it. And then he is not making it in school. There are no role models and so on. I have a friend who was just telling me Sunday night, he is a young man. He is teaching a class of 4th grade males who are very, very angry, fighting and so on, cussing out parents, teachers, everybody who's within reach. And some of them are being runners on the street. He has 9 of them. And he's the first black male they have seen in a classroom. These children are not in anybody's church. So, that whole issue of that anger, that mental illness, and what is their life expectancy. And I know just looking at the news, these 14 and 15-year-olds that are killing people and robbing people, and you wonder, why aren't they in school at this time of day? Have been such of a problem that they are no longer in school? Yet we're going to spend millions of dollars on the opioid crisis, but we are not dealing with the issue of our children to help them so that they will not become a part of that population or the prison population. The fastest growing industry in America has been the privatization of prisons to warehouse who? 66% of the people who look like us.
Mm-hmm. Dr. Sullivan, yes, please.
I was going to say, let me weigh in just for a second on this notion of cultural competence in line with the previous comments. And in doing so, I'm going to attempt to move from the descriptive to the prescriptive. I don't want the your audience, to think that all hope is lost, because I think that the question is one of political will. The thinking is out there, programs are out there, there are models that exist that tell us how we might better do these things, but we need the political will to actually do them. So with respect to competence, the very first step, and it's a huge and important step, is to actually have that conversation, is to say that cultural competence is important, that there is an issue. So the reason it's been overlooked so long is because, largely because white maleness has been considered normative. And you have all sorts of norms, heteronormativity, whatever you think of as norms, you think that's the way the whole world behaves.
Yes.
And so you don't think about that. Well, everyone may not receive information in the same way. So the first thing to do is just ask the question, to think about it. And then once you realize and start to unpack this sort of normativity, then you're able to reach people in a more effective fashion. Now, I think that we can't just limit it to people of the same race, because the numbers just don't work out.
No.
Just as a practical, pragmatic matter, the numbers don't work out. We ought to train everybody. About issues of cultural competence. And in fact, I'm partnering right now, as a matter of fact, with a professor at the Harvard Medical School, and we're designing a course on cultural competence for both medical students and law students, because it's real across a number of areas, including schools and teachers and so forth. So we have to be thoughtful about that. But as long as we're closed as a culture to thinking about the notion that people may receive information differently, then it never advance. But the second we start asking those questions, then we can have these marvelously creative programs that actually reach people and do the thing that we're trying to do.
No, that's excellent. I like your whole idea of first having the conversation. First having the conversation. Well, we're going to shift a little bit. We are at a point now in our segment of time together today that we're going to entertain some questions that have come from our audience, and I am going to most likely make them a free-for-all, and if I'm not getting the response I want, I'll call you out. So this one is, how can we create another war on drugs that is effective? How can we educate law and policymakers that the war on drugs did not eradicate drugs in America? First of all, do we want to have another war on drugs? And then two, if we did, how could it be more effective?
I do not think we should have another war on drugs.
Why do you think that?
I do not think the first one worked. I don't think that you can ever eradicate drugs from our society. And the war on drugs, however it's led, will inadvertently affect some people more than others. And in this conversation, I think we all know it would affect racial minorities more. So yeah, I don't think we can really have, and you know, the other thing is, every time we talk about using the criminal justice system, I mean, I think the criminal justice system certainly plays a role in addressing this epidemic. But I think when we talk about that being our sort of main instrument, if there's somebody sitting at home that's addicted to substances, addicted to opioids, and they're thinking, if they're even getting to that point of contemplation, and they hear, well, we should arrest these people, we should not do this, we should lock them up, they're not going to come forward. That's going to be a huge deterrent. That's the type of stigma we don't often talk about. Just the policy recommendation in itself creates some additional stigma where people think, well, I'm not going to talk about that. They think I'm a criminal. They think I should be locked up. So I just don't think it's, I don't think it's the primary instrument by which we can address this problem. And I don't mean that just this opioid epidemic, but I mean substance use and abuse in general. So.
I think I agree with that. I think war is the wrong metaphor to talk about how we deal with this issue of drugs. So what happened with the war on drugs is that it only addressed one dimension of the problem, and that's why it was so successful. That is to say, the notion was we can win the war on drugs by arrests and incarceration. What they neglected to understand was that that's only one aspect of the problem. In order to deal with drug epidemics, one has to deal with the structural issues that give rise to the problem in the first place. We have to look at education. We have to look at access to health care. We have to look at provision of drugs themselves. That is, how do they get into the countries? Jesse Jackson used to famously say decades ago that, all these people you're throwing in jail, they don't have airplanes. They're not bringing this stuff into the country, right? So we have to think more critically about interdiction. It's a multi-dimensional problem, and if you only deal with it or primarily deal with it, I don't want to overstate, but primarily deal with it by incarceration of street level dealers and users, then you're missing the vast majority of the problem.
Right. And I think it's fairly well documented now. The war on drugs largely got its wheels going after urban African Americans. So I mean,
it has been very effective in that regard.
Yes,
So I would say the war on drugs, depending on what the objectives were, has been very effective. With unfortunately a detriment to a particular segment of society.
Yes.
Anybody else want to add on to that? Just want to remind you that you are able to provide your questions or submit your questions via YouTube, live chat, or Twitter. So please do so, and we'll get them up here and hopefully asked. What can be done to increase access to treatment and prevention in typically underserved communities? And maybe Dr. Bush, could you speak to the prevention side? What if anything?
So prevention of just opioid abuse, basically. So I mean, clearly, if patients, I guess we can look at it this way. Going back to educating doctors about the cultural sensitivity, when I was in medical school, we were educated with that. I think we need to open ourselves up to all patients. We need to be clear that we are offering opportunities for everything, for all races and socioeconomic statuses. In terms of, we have to inspire doctors to want to go to those communities that are not as wealthy, but who want to then treat and help and educate patients. And that's it's hard. I mean, that's definitely hard, but that's clearly needs to happen.
And when you get them in smaller communities, you cannot overload them with patients.
Right.
And that, I've seen it in Grant County, and I've seen it in other small communities around. And within 7 years, they're burned out. And you wonder why they're ready to leave. But in the same light, I also think that money will have to be put into place, and I know that's a dirty word, but that will entice and help to cut the expenses for doctors. Because to go to medical school, what are we talking, $200,000, $250,000, and specializes even more. And then you have those huge bills. But in the same light, looking at certain specialties, looking at communities and underserved populations, and being in a network where you can get them the type of care, and making sure that general practitioner is not the only person there, so that that person has another doctor that they can rely on. And CRUs, what is current, and how do we keep people current so that they won't over medicate? I have a real problem with the FDA, and I'll say it because the FDA knew what these drugs were, the prescribed drugs effect, yet they allowed their reps to keep pushing that. Why would a person have a simple tooth pull, need 30 days of OxyContin or some other high-powered drug? That was way too much. Now, the state law, with their new program and so on, are looking at each other, but how many people are hooked and so on after the fact? I'm glad we are doing something about it, but it's a scary thought. And, you know, all of that again is that education and also looking at what it is that we are dealing with. And people in poor communities don't have a lot of money.
Sure. And the pharmaceutical industry
Definitely
is a very
a part of
effective
this.
lobby, and it's a part of the equation.
I just want to
Yes.
say, I think like in terms of like not only just educating the new doctors, but we need to have people come back and re-educate
Right.
other doctors. Like I myself as a specialist, so I know how to prescribe. I have an understanding of how strong the medications are that I'm giving. I educate my patients about the medications before I give them to them, what not to take with them, how you should feel. And like I said, I evaluate my patients monthly. I think primary care doctors or surgeons, they're not comfortable with sort of how much can I give? Well, I just want my patient to feel okay. I don't want them to complain of pain, so they give them too much. And they're not there to monitor them. I think you have to re-educate about dosing, about what drug is stronger than the other. How should you dose it? How long should you dose it? When should you evaluate that patient again to ensure that this is appropriate medication?
Well, it seems like even you're an anomaly in the fact that you are having contact with your patients on a monthly basis.
Yes.
That doesn't happen for the majority of...
But for majority of good pain clinics, it is.
Right,
You
that's what I'm
see-
saying.
yes,
For
yes.
the populations
Oh,
that are underserved, that's not the
yes. Right,
case.
and I have a
Yeah.
relationship with my patients.
Right.
Like we have a relationship. I know about their families. I know what's going on in their lives. So I can appreciate when things are appropriate. Like, oh, we can come down this month because you're doing much better. I see you doing these things. I sort of check off and I examine them every month.
Right.
And those are all things you have to do to assess if an opioid is appropriate for a patient.
And I will say in terms of like, even if we build up treatment, we need to think about how people are getting into treatment too.
Yes.
We need to decrease the barriers to it and increase the access to it and create opportunities where people can get into treatment. And so, yeah.
I think you all have answered this question, but maybe you can answer it in a different way. What is the potential negative impact on minority populations from the current response to the epidemic? So, given that we now are calling it an epidemic, and I think we've kind of settled on why now we can say it's an epidemic because it's reached the majority community, what is the potential negative impact on the minority populations from now the response that is coming about the epidemic? From a public policy standpoint, funding standpoint, just in terms of people talking about it now?
So, my thought and hope and prayer is that it's going to be net positive. That is to say that we're dealing with this with a medicinal vocabulary. But you pointed out what may be some potential shortcomings. That is, will funding from federal sources and state and local sources be different as a function of different communities? Will police forces at the local level treat people differently as a function of race or ethnicity? I hope not. So my hope is that we as a country, as a culture, realize that this is an issue that impacts many people, color, culture notwithstanding, and that we ought to deal with it in a certain sort of way. But time will tell. So for now, I'm going to be an optimist and encourage all the legislators and decision makers to treat people equally with respect to this epidemic, and we'll see. And if not, then I'll file a lawsuit.
That's the American way, yes.
There we go.
This question, I'm going to give it to you first, Brad. What harm reduction tools need to be considered in order to reduce death, disease transmission that stem from drug use in minority communities, and who should pay for them?
Somebody teed that up. I'm a big proponent of syringe exchange. I know it's controversial. I understand entirely why it's controversial. But there are so many of these individuals that are dying are not being seen in any traditional treatment system. They're not even being seen by EMS. This is an outreach effort that can potentially engage people into treatment. It can reduce infections. It also, I will say too, as I mentioned, we have over 300 people dying in this county every year, and over half of those have fentanyl, right? So how do we educate people about this fentanyl? Through syringe exchange. And more than educate them about the dangers of it, there are strips that we can provide to people where they can test to see whether or not their substances have fentanyl in them. And unless we create spaces like that provide an opportunity for active users to come to get help, I think we're going to continue to see these deaths shifting disproportionately towards lower socioeconomic groups that have no access to any care whatsoever, and or seeing them continually ending up in the criminal justice system. So that's the #1 harm reduction strategy I think we could adopt.
Okay.
We need to educate. And it goes right back to what Brad said. If we're not educating people, and it may come to a point where we have to have clinics with therapists and so on, people who know how to educate and who will not look down on a person for that, to make sure they understand, as a productive member of society, what does that do for their children? What does it do for the wife or the husband, and so on, in that relationship? What does it do for your community? And how do you become a productive member of society? We say we want a workforce drug-free, but we are not putting the money nor actions towards that mentality.
And let me just to expand on that, this drug-free workplace stuff, I mean, we could change our mentality around that to see it as an opportunity, right? Yeah. When somebody tests positive for drugs, that's an opportunity to engage them about potentially getting help with that. So I think we can stop thinking about this drug-free and maybe seeing these more as opportunities. So, yeah.
Do you see this having more traction in more progressive progressive communities that are on the political spectrum versus more conservative?
I think just looking across national data, we'd see that, yeah.
So what does that say for Indiana?
We need a lot of work.
Okay. I'm going to leave it at that answer. We read about pharmaceutical companies and hospitals with large quantities of drugs missing. What efforts, is that true, missing? Okay. What efforts are in place to stop this through the justice system? I didn't know that.
Me neither.
I mean, I will say that right now, this is my understanding of INSPECT. The criminal justice system has access to our prescription drug monitoring data. So they can see if somebody, they pick somebody up, they have a pill, did they actually have a prescription for that pill? But I think we can use the data in more sophisticated ways. So, for example, we could identify who is prescribing the most amount of opioids. And we don't need to send law enforcement there, we could send a letter there. And when that letter arrives, if you happen to work at a pain clinic, you're going to say, well, no crap, I do this because I work at a pain clinic. But if you're at a dentist's office, if you're a veterinarian, if you're, then it could be, okay, well, here's some tasks that we could do to reduce that. Right. And I think if we can start to identify where those places are, I think, again, educating them about other practices, some of these multidisciplinary practices that you were describing earlier, I mean, these could be options that folks might take. But we need to use that information in a different way to potentially understand where diversion is occurring. I think that's going to be one tool we have to do that.
Excellent. Anyone else?
And if that is happening in the medical sector, and it has been for years, how are they dealing with the problem? And what programs do they have that they are instituting or have instituted in their workplace environment to keep that person a productive member of society and employed? Think about AA, Alcoholics Anonymous, and going through treatment and so on. And what are the ramifications and so on. And that is a generational, I'm not going to say curse, but it repeats itself in families. And nobody wants to talk about that ugly little secret. They function every day at work, but after work and on weekends, they no longer function. And what is the impact of that? And why aren't we using some of the practice that we see in the private sector for the whole sector?
That kind of leads into the next question a little bit. How do we train providers to be in relationship with their patients when insurance companies too many times dictate what a provider offers?
It's very difficult. So when you see a patient, you want to give them the best thing that's out there for them,
Right.
for whatever it is, treatment, interventions, medication. And insurance does, it limits, we have to do prior authorizations, or they'll say, no, they have to try this drug first before they try another one, a drug that might be ineffective. And so while we're educated to want to prescribe the best, we also know how to use the system to get what we want. And we tell a patient, we have to start you on this drug for a week, and then you can come back and get a drug that's going to work better. Or we have to do this therapy before we can do the definitive treatment. It's difficult, it's hard, and that's sort of the problem with sort of the government says one thing, we want you to do interventions and these pills and these medications which are less addictive, but insurance says, nope, you can't do that. You have to do this one, and you can't do this therapy that's going to definitively help this patient, and no, they can't do this, but they have to do physical therapy first, but nope, they can't walk because they're in so much pain, but they have to do that first before they can get an injection. It's very difficult. It's very difficult.
Well, this,
And, you know, I'll just pipe in on that issue as well. We talked a little bit about class, but there's a class register that rears its head with respect to these issues as well. And oftentimes race and class conspire with each other for the absolute most negative results. But class is an important issue here, simply because people with resources can do one of two things. One, tend to often insist on better care because they ask more questions and are more confident about asking questions, or two, I once, for a number of years when I lived in DC, went to a physician that didn't take insurance. You filled it out yourself and put it in, and so you had to pay real time. The benefit was that you weren't rushed, that you sat there as long as you wanted to, you talked, and you felt that you got care. But everyone can't afford that. You know, everyone can't afford to float, I don't know, $800 a visit or whatever, and then fill in paperwork. So we have to figure out a way where people of various means can receive the same sort of health care without undue pressure on physicians to sort of get people in and out very quickly. Yeah. 15 or 20-minute increments. Yes. The physician on the panel will know much better than I, but in any human interaction, as a lawyer, as a doctor, some things just simply can't be solved ex ante. That is, in some time frame that is imposed before a visit. You just don't know. And if there are these external pressures for volume and to move people, then it gets then things get missed. So that's one issue that I would throw on the table as well.
Right. No, and it's a good one, and it leads into this question from one of our audience members. How can providers fill gaps of care when opiate-dependent individuals are no longer in care? So they're not under supervision, if you will. What can we do to fill in that gap?
I mean, if we have patients who we find to be diverting or abusing their opiates, yes, we do tell them we're not going to give you opiates anymore, but we also refer them to care. I mean, and there are a few services here in ND, but we refer them to care. We absolutely do. And I also absolutely, because if I believe they really have pain, that's why I was prescribing them medication, I offer them other alternatives. Like I said, I don't think I would get them a pump just because I think they're abusing. Sure. But then I'm going to look at why they're abusing. Is it a pseudo-addiction? Are they being undertreated? Is it anxiety, depression? Is it post-traumatic stress? Like, you have to feel out what it is that's making them abuse. And then is it because the pain is just out of control? It's amazingly horrible for them. And so then you're like, okay, what is it? What have we not done? Well, let's go to a surgeon and see if this is a surgical intervention now that we need to do. It's no longer minimally invasive. I mean, that's what we do. Like, we don't leave them out to dry. But I mean, clearly there are those who are floridly addicting and abusing And I'm not really sure what you do with those. I don't know.
I mean, when folks that have opioid use disorder are not under supervision, as you put it, I mean, I think that, I don't know if it's an education or a philosophical twist, but we need to think that relapse is a normal part of the recovery process.
Exactly.
So when somebody does have a relapse and they're not under supervision at that time, that's not a failure. That's
Right.
an event to learn from, right?
Yes.
So I think that having that philosophy, if we really believe that philosophy, I think it could change a lot of our practices and how we deal with people that have relapse while they're not under
Do
supervision.
you think it also can serve, unfortunately, as an incentive to going to the illegal market to get it?
If we don't accept it
Exactly.
as, if you can't say to somebody, hey, I know you're relapsed, let's talk about it. But if you see it as just a straight failure, then no one's going to want to confront that,
Right.
right? So.
And you're going to have people who are talking to each other. And that it comes back to that trust and mistrust. Who can they talk to? And, when we do not do something well, we consider ourselves failures. And the reality is, there go I by the grace of God. Each of us can fail at something. And on a good day, I can walk away with, and I don't even drink coffee, all over myself, because I've been doing too many things trying to catch up. But when I sit down and I focus, then I could have that cup of coffee and not a drop moves any further than my mouth. And that's the reality of life. And we have to help people not to blame themselves when something falls apart, because things are going to fall apart every day.
Yes. Dr. Sullivan, you wanted to chime in on that?
No, I was just going to agree that we can't view addiction in the first place or relapse as a failure of character. It's much of the vocabulary trades on that. It is a medical issue. It is a psychiatric or psychological issue, perhaps a physiological issue, but it is not a failure of character, and we have to get out of that vocabulary.
Great. I have one last question for you. This is kind of looking a little bit forward. With the new Medicaid work requirements, how will the impact access to inpatient treatment and employment, impact access to inpatient treatment and employment with the new Medicaid requirements?
The new Medicaid requirements is that the person to receive their payment will have to be employed or go out and look. On the surface, that sounds good. Yeah, we want everybody working. But the reality, are they mentally ready? Here we go again with the big M word, mental illness. Have we prepared them to work? Do they have the necessary skills and competencies to move to the next level? And have we supported them? And are we willing to put our money there for that support? It's easy to say, hey, that really sounds good, but the reality, it's not that easy. It's far from it.
Great. Anybody else? Be thinking about just one statement or thought you want to leave with us today in terms of IMHC as it goes about doing its work and how we look at this issue. What is it that we can do, either individually, collectively, as a community, as a society, that will help to reduce the disparities that we're seeing in terms of this opiate epidemic? While you're thinking about that, I'm going to take this one last question. Someone asked, what do you think about the idea of educating middle and high school students about the opiate epidemic, going at the level of middle schoolers and teenagers to talk about this issue?
I think we're going to have to.
I'm sorry, I cut you off. Go ahead.
No, I think we're going to have to, because they are exposed to it. Whether we would like to say, no, they're not, they are. And if they are exposed, we need to be educating our children about the issue, whether they're taking, selling, or so on. Because the reality, it's happening already.
All data show that you have to talk to kids in an age-appropriate manner, but you have to. So I'll say this as a scholar who's looked at the data. Yes, I'll say it as the parent of an 8-year-old as well, that I've talked to him about drugs in an age-appropriate manner since he was able to talk, right? And as he gets older and older and older, the conversation will change a bit. But I think that you must. The cost of not doing it is way too high nowadays.
Very good. All right, so our call to action question, and your wisdom or thought for what would you leave the audience and the rest of us with in terms of our response? You first, Jocelyn.
Hope. There is hope when things are at their worst. It is never so bad that there is not a bright, shining moment every day.
Excellent.
I think a lot of this, we've talked earlier about some of the criminal justice responses to this, but I think that while a lot of this problem is getting pushed onto the criminal justice system, I have been very impressed with some of the innovative practices locally, state level, nationally, that have been getting implemented into the criminal justice system to address this. I think we need to study those further. I think we need to develop some evidence base on them. But again, I think going back to this idea of hope, that there is kind of a mind change that's happening. So I think understanding that going forward, and then also I would say, I know it gets said a lot, but this idea of reducing stigma. Mm-hmm. And stigma is not just what you're saying and how you're saying it, but our policies can implicitly or explicitly have stigma in them. And I think we need to think about that as well. So.
I think along the lines of the stigma, I think it's important that people understand that there isn't a stigma to having pain or needing something to control your limitations in life, and that there are facilities and avenues and interventions that can help you, that can minimize your requirement on a pill, but that can free you and then let you do even more things, whether it be mentally or interventionally with a stimulator or an injection, or even just therapy, or just someone to talk to every month to say, gosh, it hurts to just go care for my grandkids. And you listen to them and you say, well, we can do these things to help you out. And I think the stigma of pain clinic needs to go away, and that you go somewhere that's safe, where someone can monitor how you're getting medication and that you're taking it appropriately. I think it's appropriate.
Yes. Dr. Sullivan.
So my parting thoughts is that justice doesn't just happen. People have to make things happen. So structure impacts behavior. Citizens of goodwill, people do good, have to insist that their policymakers do the sort of innovative thinking and figure out what the innovative practices are around the country. Each and every one of us as citizens have the right to insist that our lawmakers, that our policymakers do this. And if citizens engage, then the policymakers will follow.
Wow. Great way to end. Well, thank you, each and every one of you who's been on our panel, but even those who are in the audience and are watching across the state. Again, Dr. Bush, we appreciate your being here. Dr. Bray, Jocelyn, Ms. Whitaker, Dr. Sullivan. Hopefully it's been insightful and you've enjoyed the conversation. Let this be the first place that we're starting the dialogue where many more things hopefully can come afterward. And it's now my privilege to turn it over to Tony Gillespie from IMHC.
Tony Gillespie, Indiana Minority Health Coalition. I'm the Vice President of Public Policy and Engagement. I first want to thank our esteemed panel for being here. I think we've all been enlightened and learned something that we didn't know before. Indiana Minority Health Coalition believes that this is a very important conversation, and to gain any wins and to move the needle in addressing this issue, we have to address the entire community, not just a segment of the community. And as we've learned today, that this does impact minority communities. And moving forward, we want to replicate these kind of conversations around the state in the form of opioid roundtables. So we're going to be reaching out to community once again to help us address this issue and help us move the needle on this national epidemic, but how it affects Indiana and how it affects minority communities and all Hoosiers. want to especially thank our partners here at Side Effects Media and WFYI. This was just an idea, just a concept, and to bring it to concrete and to bring it to this today has been incredible, and they've been incredible partners, so we can't thank them enough. And I want to thank our audiences around the state and our studio audiences. And if we can just end with a hand clap, because this panel has been incredible, and we were fortunate to be able to pull such an incredible panel together to make this happen. So again, on behalf of Indiana Minority Health Coalition, our partner Side Effect Media, and WFYI, we thank you. Thank you.